A year ago, we were talking with Dr. Deborah Birx at NCSL's base camp about the COVID-19 vaccine, and it was still just in clinical trials and not yet authorized for any use, for any emergency use among the general population. And here we are a year later, and we've just hit the milestone of about 70% of adults in America having received a COVID-19 vaccine dose. So we're going to dive into that today and the huge role that states have had over the last year in really rolling out and scaling up vaccines across the country and getting shots into arms. And I'll have the pleasure of moderating a great discussion today. I'm Kate Blackman, and I direct the health program in NCSL's Denver office. I'd also like to thank the Centers for Disease Control and Prevention for supporting this session and for supporting so much of NCSL's work on the COVID-19 response over the last year, and not only the vaccine, but just public health and healthcare responses that you all in your states have really been engaged in. We really hope this is going to be an interactive session for you all. We anticipate a lot of discussion and a lot of questions. So to get you warmed up, we have a quick poll question for you. So right below the video player where you see my face, there is a little button that says poll number 1. And if you'll go ahead and click on that, we are interested in how you've been involved with the COVID-19 vaccination efforts in your state. Either how were you or how are you currently involved? We know that so many of you have been on the ground and talking to constituents or talking to the public and learning more about their concerns. We've seen a number of states with task forces or working groups to look at how to roll out the vaccine across different populations. And certainly our team has tracked more than 500 bills just related to COVID-19 vaccines. So we know there's been a lot of legislation moving through states. So we're interested in you all in this audience today and what your role has been. And it looks like we've got a few folks that have worked on legislation, only one so far in a working group or task force, which is interesting to see. And then a lot of folks definitely interacting with concerned citizens, healthcare providers, I'm sure other folks at the Capitol who have an interest in vaccination efforts. So I'll give you about 15 more seconds to fill out the poll. And some of you have not been involved in any of these and would love to hear other things that you've been working on or watching in your state related to the vaccination efforts. And feel free to put those in the chat and share with each other. So we'll keep on rolling through, but before we go any further, because so many of you are engaged in this space and you're here for this session, I want to make sure you're aware of NCSL's resources on COVID-19 vaccination in states. We just released a vaccine policy toolkit that covers not only pandemic vaccination, but also routine child vaccinations and flu vaccinations and other efforts in states. We also have a COVID-19 vaccine snapshot, which is exactly what it sounds like. It's a snapshot to get few state examples and ideas of policy levers available at the state legislature. And then I mentioned our legislative tracking, the COVID-19 database. Our team is tracking thousands of bills in public health and healthcare responses to the pandemic. So definitely encourage you to check that out and always reach out to our staff with any questions. And then, as I've said, we know that legislatures have had a large role. I mean, the vaccine administration, the rollout has really been at the state level. And so we wanted to highlight the effort of some of our members. And we have a short video that we'll show now with 3 state legislators from across the country talking about their role in supporting vaccination efforts in their states. So we'll go ahead and watch that.
I'm Joyce Kravick. I represent North Carolina Senate District 31 in the North Carolina Senate. We had to hit the ground running very quickly. We had COVID funds that had to be administered. We had to allocate all those funds. We had a big bill, Senate Bill 704, that we dealt with a lot of those things. North Carolina was way behind in vaccines early on. And we had called in our DHHS and asked them to let us know what we could do to help and how we needed to make certain that those vaccines were available and given. A lot of them were being wasted because they weren't getting into the arms of folks. To her credit, our secretary hit the ground running, planned some huge events, and we were able to get those numbers up. And so we were very proud of that, very proud that we were able to increase the number of vaccines that we're getting out in a very short period of time. It was a difficult process, but we had a lot to do and we had to do it very quickly, and North Carolina is always up for the task, and we did, I think, get things done, get things rolling so that we weren't nearly as affected as we could have been.
My name is Tim Ormsby, and I have the privilege and honor of serving as the chair of the Washington State House Appropriations Committee, our budget committee. We came into this session knowing that we had to deal with the public health crisis and the economic results, and we had to do it in an equitable fashion. Our sole focus, beginning our session on the second Monday of January, was to drive out the resources that had recently become available from the federal government. Washington's share of those resources amounted to $2.2 billion. And through an early action budget proposal, we were able to distribute that within a few weeks of the beginning of the legislative session, come to agreement with our Senate partners, and have the governor sign it to get that money to the places where it was needed. We knew we needed to restore the confidence of the people, and we needed to have internal confidence in the legislature about knowing that we were making the best use of the resources that were available. As a result, we created a large non-appropriated account for the Department of Health and their partners in the local health jurisdictions to access those resources with reports to the legislature to deal with hotspots, an ever-evolving dynamic of access, to provide assurances to communities that this was the right thing to do, to identify trusted messengers within the communities to deliver that information. And fortunately, we had a robust outreach effort as a result of our census activities in 2020 that was perfected in a virtual environment. And the legislature took that structure and resources, relied on it, and got them out in a fashion that has resulted in a high percentage of vaccination rates in Washington State, with a healthy reserve to deal with the uncertain unknowns of variants and other issues that may raise themselves and need to be dealt with either before the next legislative session or immediately when we begin. I'm proud of the efforts, and I'm proud of the staff that made this happen in an all virtual environment.
Hi, I'm State Representative Tim O'Neill. I represent the 48th District in Pennsylvania. Many of us may know that Pennsylvania began the COVID-19 vaccine rollout really at the bottom of the charts nationwide. Since that time, and since a bill that I introduced, House Bill 326, became law, authorizing our National Guard to begin to assist in the vaccine distribution and rollout here in the Commonwealth of Pennsylvania, we've seen our numbers gradually increase over the past several months. We've done this actually through a bipartisan effort. After my bill became law, the governor signed it into law. The governor also established a COVID-19 task force. It was a legislative task force. There were 4 members, one from each party in each chamber of the General Assembly here in Pennsylvania, as well as the governor, who worked in conjunction in correcting the situation with the vaccine rollout here across the Commonwealth. I'm happy to say through that bipartisan, really across branches of government effort, we've seen these numbers dramatically improve over the course of the time since the initial rollout. Like I mentioned, we started off 49th in the nation. We're now 9th as far as total vaccine distribution, and we're first amongst the 10 largest states in the nation. Hesitancy remains a factor, especially amongst younger groups throughout the Commonwealth. But we're through this effort in this task force, we've put forth an effort in a campaign to overcome some of that hesitancy. So we're seeing great success here in the Commonwealth. To the best of my knowledge, we're the only state that's taken this approach of across branches of government through our legislature as well as the executive branch, taking this approach to address these issues and truly turn the ship for the success we've seen across the Commonwealth.
All right, so now it's my pleasure to introduce our wonderful panel today of experts from national experts and state experts. And their impressive bios are on the page down below. You're welcome to read all about them, but I'll briefly introduce them. First, we have Captain Amanda Cohn, also Dr. Amanda Cohn, who's the Chief Medical Officer for the Vaccine Task Force and the National Center for Immunization and Respiratory Diseases at the CDC, the Centers for Disease Control and Prevention. We also have Brigadier General Janeen Birckhead, Assistant Adjunct General in the Maryland National Guard. And then all the way on the other side of the country, we have Matthew Bobo, Alaska's Immunization Program Manager and co-lead of Alaska's COVID-19 Task Force. So thank you all for joining us today. I'm really excited to have this conversation with you, and I'm going to encourage our audience to go ahead and, as you're talking, to be putting their questions and thoughts into the chat and into the Q&A box. But just to kick us off and kind of ground us a little bit, I'm wondering if you can each just tell us a little bit about your role in vaccine distribution over the last 6 to 12 months. And we'll start at the national level with Dr. Cohn.
Good afternoon or good morning, everyone. And thanks so much for having me talk about one of my favorite topics. This has been just an incredible challenge, but also opened up a lot of opportunities in the immunization world over the last year. So we started planning for implementation nationally for vaccines probably last March or April. And I would say my role is twofold. One, over the course of this period of time, I've been the executive secretary for the Advisory Committee on Immunization Practices. And that's the CDC advisory group that pulls all of the data on safety, effectiveness, burden of disease, who should get vaccines, when, if, questions like, are we going to need additional doses? Those are the questions that group tries to provide or does provide advice on. And I've had the honor of leading that group from CDC's side. And we've had over 10 emergency meetings in the last year. I think we're at 12 or 13. And this group of 15 experts has just worked around, throughout the entire year to provide the best evidence-based recommendations for these vaccines as possible, and has remained very fluid. So addressing vaccine safety issues, vaccine effectiveness issues, and all of those questions regarding the differences between the vaccines as well. The second part, so those recommendations really lay the foundation for building trust and having healthcare providers understand what to do and our jurisdictions. But the second part of what I've been doing is much more focused on the national distribution. So there's two strategies in which nationally we focused on getting vaccines into people's arms. And the first, which is our bread and butter strategy of all time, is to go through our jurisdictions. So going through states through their immunization cooperative agreement, and the states then work with local health departments and local communities to think about where vaccines should go, where there's too much, where there's not enough, ensuring equitable access. Those have been really key factors. Every state has different challenges, some of which I think we'll hear about. And our goal was to work with those jurisdictions to support them in whichever way they can. The second piece of the way we implemented this vaccination program was through some specialized federal programs to try to expand access. So things like federal entities such as using the VA, Indian Health Service, other federal agencies to support vaccination efforts, but then additionally using streams of distribution such as through pharmacies, our long-term care facility pharmacy approach, where they paired up with long-term care facilities to get vaccines there quickly. And things like dialysis units, federally qualified health centers. So that sort of takes some of the burden off of the jurisdictions so they can really focus on where the gaps are. And I think I'll end there. Those are sort of the two major things that I've been part of over the last year.
Thank you. Both very big efforts. And now I'll turn to Maryland and General Birckhead. Tell us a little bit about your role.
Hi, good morning and good afternoon, and thanks for having me. And we've been involved, as many Guard states have been involved at various levels during the first part of COVID, when we were working in the communities, whether it was working with schools or distributing food or helping the communities as we could with PPE and those types of things. Then when we turned to vaccine, we were very much involved with the on the ground effort. And that was one of the first things that the governor asked for, was to have a plan that was operational and that we could really get in and immediately hit the ground running. And I reflect on Dr. Cohn's comments about the vaccine distribution, because that was something that was very important for Equity Task Force to be able to have the vaccine to actually distribute. So we were very involved in how that vaccine would be distributed and ensuring equitable distribution across Maryland. Maryland's 24 jurisdictions, who are very different in the way they're made up, the ground that we have to cover, and the communities at large are very diverse. And so it was important that as the Equity Task Force, we looked at the data and have a very intentional approach that was data driven, and then on the ground, having people who know the community working with us very closely. Our community outreach and engagement was very robust, and we realized from the beginning that, much like many states, it was the communication piece through language barriers, or it was technology and IT that we had to overcome, or whether it was transportation that we had to overcome, or communication and education. So the Equity Task Force set out a plan that would address all those areas. And as we evolved, and as the vaccine distribution became more prevalent and we were able to get more vaccine, and the communities became more willing to take it, we had to pivot our processes. And now, as the communities are not getting the vaccine as much as we would like, we've actually been able to and had to pivot to change our approach. So those are some of the things that we've been doing, and I'd be glad to discuss that as we go out this next hour. Thank you.
Great. Now I'll turn to Matt in Alaska.
Good morning and good afternoon, everyone. Thank you for having me. So at the start of vaccine distribution, Alaska formed a vaccine task force. And it was really important for us to partner with our tribal partners. So we had a co-lead for each member of the task force, and we partnered with the Alaska Native Tribal Health Consortium and had co-leads on each of the task force. At that time, I was responsible for vaccine operations, which included vaccine distribution to healthcare providers. As the general mentioned, really the theme of my response in Alaska was pivot. We did a lot of pivoting and a lot of changing strategies in order to meet needs. So we've now reorganized the vaccine task force in order to adapt to the ever-changing landscape that is COVID-19. And now I'm now responsible for the task force as we continue in this response.
Great, and I think we thought pivot was sort of the word of 2020, but it turns out it's really been carrying forward into 2021. Matt, I'm going to sort of come right back to you. I know there's a lot of challenges that states have had, and we're going to unpack some of those, but maybe let's start with a high note and talk a little bit about some successes. And Alaska is a huge state, as our Alaska members often remind me how large Alaska is compared to the rest of the country, with some really hard to reach communities, accessible by only certain modes of transportation. And you all had some real success right out of the gate. I'm wondering if you can talk a little bit about that and how you reached some of those hard to reach communities and populations.
I'd be absolutely happy to chat about that. So vaccine distribution in Alaska, it's a complex story. And Alaska as a state, as you mentioned, is unique. We have no counties. We have a complex public healthcare system operated mainly by the state. And we have a unique tribal healthcare system, which has tribal health organizations that service tribal villages in rural, remote locations. So just kind of starting with a little history, immunization programs in the lower 48 or the contiguous United States switched to centralized distribution of vaccines in 2008. meaning that we had one national distributor, that is McKesson, sending vaccines directly to healthcare providers. So due to the geography of Alaska, we waited until 2018 to make the switch over to centralized distribution. Before that transition, we really operated a state-run vaccine depot, and the state shipped all the vaccines to all providers. With the transition to McKesson, Alaska learned a lot of lessons in 2018 for vaccine distribution, which really benefited us in this pandemic. So big lesson number one is Alaska standardized vaccine distribution from tribal health organizations. And these health organizations are really in hub communities about 3,000. And then they ship the vaccine to tribal villages, which are about 50 to 100 people. And we required tribal health organizations to basically ship vaccines in Vericore coolers. These coolers are storage units that can hold temperatures to 3 to 4 days. So again, we're shipping vaccine that has to be at a certain temperature. And then we also required to have continuous recording thermometers in each of those vaccine shipments. And so we really standardized the way that their tribal health system shipped vaccines to these rural remote locations. And lesson number two we really learned is that McKesson or national distributors, they can't get to every location in the state of Alaska. So there are approximately 17 locations in the state where the state really has to take over. So the state intercepts the vaccine shipment in Anchorage. All the shipments come into Anchorage as the main city in the state of Alaska. And then we basically reroute these vaccine shipments to more remote locations using remote kind of in-house airports and airlines. And then we kind of basically have a 3 strikes you're out rule. If you can't get to a place and kind of 3 times, then we're going to take over and we're going to make sure that the shipment gets there. So when the shipments arrived in December, kind of these logistical kind of chains that we've worked out really proved to be effective and efficient, even in the darkness and in the cold of December. So we're really lucky in that regards.
Sounds like you had some great lessons learned, and we'll talk about even more lessons learned here in a moment. I'm going to turn to you, General Birckhead. It's sort of a similar question, and you mentioned this in your opening, you know, that Maryland has a lot of different 24 jurisdictions that all look a little bit different. And that equity was a big focus. So I'm wondering if you can talk a little bit more about how Maryland addressed or enhanced equitable access to the vaccine across those rural and urban communities and different populations.
Yes. So one of the first things we did was to look at, I'd mentioned the data. Well, we were data driven initially, and we came up with a Maryland composite that looked at the same things that the CDC looked at, but we added a few more things to that. And we came up with composite maps that would drive where we would go. And then we would look for being from the neighborhoods, the National Guard being people who come from the neighborhoods, searching for people who might know the community. And then one of the other things that we did partnering was with the faith-based institutions early on. And we found that to be very important and actually made great strides into communities by working with the faith-based organizations. And that's where we found some of our early wins. And one of the things that with those types of clinics was making the communities feel like they were empowered and explaining to them how they could actually work with us to get vaccine into their communities. That vaccine distribution part in the very beginning made it very difficult with the limited vaccine. And our intentional plan using the data, we were able to demonstrate to the larger Maryland state government working with the Maryland Department of Health that equitable distribution needed to be intentional. So it was great that the Vaccine Equity Task Force was not limited in the vaccine we needed as we had our clinics come in, request for vaccines, or were able to simply demonstrate that the community need was there and the community was ready to get the vaccine. So we set up an intentional plan with community outreach people that were assigned to each county. They would work with that faith-based group or a healthcare organizer or a Boys and Girls Club would have you set up a clinic. In the beginning, there were clinics that we were doing, and then we would go to that clinic, bring the vaccine. And then from the National Guard perspective, we had medical professionals that we could bring in to walk through a church, if you will, or a community a location and say, yes, this is how you set up a clinic. We want you to be safe. We're going to bring providers and wraparound services. And key to when we thought about equity is making sure that we then had those correct services to get the vaccine into arms. So before we do that, how do we get them into Immunet, or how do we get the vaccine actually registered properly and that it counts? How do we store and how do we move the vaccine? And then how to communicate with the people on the ground to make sure that we are providing the right information. And then that we have somebody there that communicate in that language, whether it be another language or sign language or what have you. And then on the end, again, being able to, when we realize that our faith-based institutions, they've got it, continue to provide assistance, then we have to move to other populations, such as when we move to pop-up clinics. And we find that those are working really well in our urban areas. We can go to a location, set up very quickly, and it's expeditionary in its model. And maybe the day before, our community-based group will go out and look and find out what the best corner is to set up or where the best location is. And then the next day we're there with the vaccine, with the provider, and we put shots in arms. And we found that to be very useful. Just as on the rural parts of Maryland, mobile vax is probably our go-to. So we can go to a location, bring and set up our mobile vax very quickly, have people even drive through with our mobile vax set up working together, and then later on that day move to another location, but being mindful that we're in a rural location and we have to be able to move quickly and communicate, again, in several different ways, whether it's through IT and having a computer or a laptop, or whether it's just going old school and using paper, and all those types of things when we think about equity were really important.
Thank you. I think we've heard so much about the importance of community partnerships and increasing vaccine confidence and equitable access. And it was really nice to hear, how you operationalize that, how you really made that work and partnering with faith-based groups and others. So I'm going to turn now to, what we all want to talk about. What are the lessons learned, and talking a little bit about the challenges. And I think with vaccines in particular, in the last few months, we've seen just unprecedented collaborations and partnerships, private sector partnering with public sector. And so I'm wondering, we can talk, I'm going to come back to you, General Birckhead, if you want to elaborate just a little bit on how the National Guard and the Department of Health came together. And then Dr. Cohn, if you'll talk a little bit about some of CDC's partnerships.
Absolutely. So with the Department of Health in our 24 jurisdictions, we initially asked for the departments of health throughout those 24 jurisdictions to please share what they saw as a plan for equitable distribution, because it had to be a partnership, and we realized that early on. And while the counties were dealing with a lot themselves, what the National Guard could bring to bear were those extra resources and once we had a trusted partnership, that they realized that we could be in their communities, actually bringing vaccine into the communities with their help or without their help. But we were all working to that same goal. And I mentioned the faith-based community, but I also want to mention the universities. And in this case, the HBCUs, the historically Black college universities that we work with. At Morgan and Bowie, we both set up mini vaccine clinics there, where we were able to vaccinate the students, the administrators and teachers and professors, and then bring in the community as well. And the one at Morgan is still up and running today. I'd also like to mention CASA, which is primarily a service to the Latinx community, where we were able to partner with a healthcare provider and have her bring her services to CASA. And actually that is still running today. And it's in a primarily Latinx community, being very culturally competent about building those community resources and creating an environment where people feel empowered to continue to do this work with or without the Guard. So ideally, when we set this up, we were intentional about making sure that the community group that we were working with felt very comfortable that they were able to continue and had the touch points in the community to continue. One of the other partnerships early on that was very important to us in Maryland, we have some fabulous hospital systems, whether it was a University of Maryland system, that's UMS, or whether it was MedStar or Luminous. We also worked as the Vaccine Equity Task Force with all of those entities on several different clinics, bringing them into support, as well as the pharmacies who also partnered with us, the different pharmacies, CVS, Rite Aid. We actually partnered with the pharmacies to set up clinics and bring them in as well. So it was really quite a robust team once we got up and running, and I think our numbers bared out that we were able to be successful. And just a mention to what Matthew said about partnering with the tribal entities in Alaska, we are certainly a much smaller population and not federally recognized tribes, but we did the same here in Maryland with Piscataway, Kenoi, and actually brought a clinic to the tribal communities. And that was very important, realizing in Maryland, we have both federally recognized entities, particularly those that are working for the federal government, and we work with those tribal organizations as well to support that community. So those are some of the things that we did in partnership. MDH with the medical professionals, those hospitals definitely, and then with those pharmacies, and then the 24 jurisdictions, and then the National Guard, bringing it together and operationalizing it and demonstrating how we can be expeditionary and get it done in a safe manner is how we've been able to be successful.
Well, I know that Maryland wasn't the only state that partnered with the National Guard. That's wonderful to hear about. So Dr. Cohn, I think the CDC partnered with the Department of Defense, but I'm sure others. Tell us a little bit about some of the partnerships you've been part of or seen.
Yeah, so partnerships has been really essential to the success of the vaccine rollout. I would say we work with partners at multiple levels. One key thing that was so important was just constantly communicating with partners. And so we tried to have as many all partner calls, national organization calls. We tried to educate through our partners. So we would participate as often as possible or asked on provider organization calls to make sure healthcare providers were up to date and had their questions answered, as well as the healthcare community broadly, healthcare systems. And then as vaccine rollout continued with national organizations that serve and support community-based organizations who are really critical to the success of getting vaccines in arms. And there's sort of three ways that we did partnerships. We also partnered across the federal government. And a lot of what we did was in connection with the lead agency. For example, CMS, we held weekly, I think it was weekly fireside chats with CNAs and other workers in nursing homes as staff were being offered vaccine really early. One of the best things we can do is answer people's questions and provide them with the best information possible, and then with the tools that our partners can use to implement locally and in communities, and they can adapt these tools to their own needs. So really keeping as much information in a way that is accessible, translated in as many languages as possible, but also letting our partners use those materials and adapt them. And then we were able to fund quite a lot of partnerships over the last several months. And one of the key strategies we had in doing that, CDC is, we work through our state and health departments really quite extensively. And so we were able to provide funding to health departments through our immunization cooperative agreement, but we focused those funding opportunities on building relationships with community-based organizations. And we really pushed health departments, most of which were doing a lot of this great work already, but at least we were able to sort of direct some of that funding to support local implementation through community-based partners and faith-based organizations. We were also able to fund several large organizations that could then, such as the National Urban League, National Medical Association, and Unidose, and other types of larger organizations that could then support their chapters and their local organizations with vaccine efforts. I think one of the key things is that the general just said was that they worked to ensure that distribution was intentional, equitable distribution was intentional. And one of the key lessons we learned quickly, unfortunately, but I think I've also adapted to quickly, is that it's not just intentional just equitable distribution, which I love the way you put that, you described that, but it's also administration. And so early on, if you remember, we were making sure that doses were being delivered to communities, but they weren't effectively getting into the arms of the members of that community. We were having a lot of people who had better access through the social media and the internet to make those appointments and to get into those places. And so it was really rapidly shifting, having, for example, using pharmacies, partnering with pharmacies to block off times in their schedule for people who are in their community, as opposed to using their online scheduling systems, and working with all of our partners to address that initial challenge of, it's not just enough to make sure that there's vaccine available. You also have to make sure that people can get there. Transportation needs are met, their communication needs are met. We recognize that very quickly that older adults, when everyone was wearing masks, older adults often couldn't hear. So some of those large FEMA-run clinics were very confusing. And so we needed to get vaccine into everybody's community in a way that was accessible to all types of different people. And so it took really everyone to support that effort.
Wonderful. And so I'm going to steal your words, Dr. Cohn. You said the best thing we can do is answer questions. So I'm going to remind our audience that I expect you have many questions. It's day 2 of base camp, so I think everyone knows how to do it, but next to the chat, there is a Q&A tab, and you can put your questions there, and you can upvote other people's questions. And we'd love to hear what state you're coming from too, if you'll add that in. And we're going to shift a little bit more to the future, which is where I think most of us, myself included, where our questions really lie. So as I mentioned earlier, we know we've hit a milestone. We have 70% of adults in the US who received at least 1 dose of the vaccine. We know it still varies a lot by community, as you all have been discussing. So what efforts are you seeing either in your state or nationally that are increasing vaccine confidence and that are helping getting shots in arms? Certainly, I think we've touched on some, but I imagine there are others. And Matthew's been off the hook for a minute. So Matt, I'm going to turn to you to tell us a little bit about Alaska and what you're seeing to increase vaccine confidence.
Absolutely. So Alaska started off with large mass vaccination clinics in kind of areas that were accessible to people. And as we pivoted and changed with the ever-changing pandemic, Alaska has started a Sleeves Up for Summer campaign. And that started in May. So we offer vaccination services, meaning shots in arm, at community events. It's supported, again, we don't have counties, so it's supported by the Alaska Division of Public Health, Section of Public Health Nursing, and a state contractor. So upcoming events include Salmon Fest 2021, which is a music event. We're also going to be offering vaccines at the Alaska State Fair, which is a big, large event that's widely attended. We're partnering with the NFL to have an NFL player come and promote COVID-19 vaccine. And we have expanded the campaign to now include a Sleeves Up for School campaign that focuses on increasing state-required childhood vaccinations, as well as COVID-19 vaccines for 12 years and up. We are also conducting a vaccination reminder campaign, reminding individuals with a postcard for their second dose. We started off with texting. It didn't go over so well in the state of Alaska, so we moved to the old school postcard. We are evaluating 4 messages to see which message most resonates with Alaskan individuals to get them back for their second dose. We also have an online request form for requesting a vaccination event. So for example, if you have a disability or you're homebound, we'll come to you to vaccinate. Just fill out the form and we'll come to you. We also have another online request form for vaccination education events. So we have a speakers bureau that we've created with volunteer medical doctors who go to events and answer questions. As Dr. Cohn mentioned, it's important just to hear people and meet people where they're at and kind of get the message out.
And I'm going to include a shameless plug for Alaska and for NCSL. We loved your Sleeves Up for Summer campaign, and it's in our vaccine policy toolkit that we've put the image in there. So anyone who's checking that out will see a photo of the Sleeves Up for Summer. It's a very cute image. So General Birckhead, I'm going to turn to you back to the issue at hand here with how are we increasing vaccine confidence? We know there's still a number of folks who are a little hesitant or have some concerns.
Yeah, and so some of the things that we're doing, I mentioned as Alaska did, we had the mass vax as all states did, and then we moved to mini, then we moved to mobile, and now we're doing the pop-ups, which are quite interesting. And last night I hit 4 of them myself. We had national night out across the country. So we set up vaccine clinics at the national night out events and did quite well. And then one of the things that we're working with in 2 of our counties and 2 of our jurisdictions is with the homebound. And initially we've done a couple of pilots, and now we're going to continue to implement that. And working very closely with MDH, and Maryland Department of Health is in the lead on this. And they are doing the door knocking, and then we're coming behind with the vaccine and doing the clinical piece and the weights, et cetera, in the home. And that's been very successful. We're seeing some uptake in that. We're doing that in a primary rural neighborhood. And then we're also doing that in a rural and in an urban setting as well. And so we're seeing that we're getting success with that. Some of the other things that we've had some success with is, and I say McDonald's specifically because it was a McDonald's, we partnered with a local franchisee who allowed us to set up clinics at their McDonald's. And the idea of these McDonald's were in communities. So we would have people that just going there for their coffee in the morning, they're just sitting down and chat, read the newspaper. And so we were intentionally trying to get those people to take the vaccine, and recognizing that, again, those neighborhoods where they were in the community, those franchisees actually went out into the neighborhood and papered the neighborhood with the flyer themselves saying that we were going to have the clinic. And having been in those neighborhoods for so long, they were well known and they knew their residents, and it went over well. And some of the other things that we did early on, working with the vaccine headhunters, back in the day when it was hard to get, they brought to the attention that a equity line was needed. So our equity line in Maryland that we stood up was called No Arm Left Behind. And through that, if you weren't able to log onto the website and fill out that form for a request, if you weren't able to call, you weren't able to text, you could actually call that No Arm Left Behind number. And that was specifically trying to get at equity. And we would go through the options with a person about how and where and when they could get the vaccine. So those are some of the things that we're doing. In addition to using the Trusted Voices, we found that we had a Trusted Voices campaign, and we continue to add to that. But we're also continuing to diversify that Trusted Voices. And one of the things that we're going to do as an event to demonstrate and show that we have success, but also show that we have some work to go, is working with our educators. And it's called the Youth Educators and Cultivators event that we're hosting on August 17th in conjunction with Maryland Department of Health and FedEx Field here in Maryland. And FedEx has allowed us to use their venue, and we will be bringing in partners such as MedStar, again, Community Health with Blue Cross Blue Shield, Prince George's County, the Department of Health, Bowie State University, Luminous, to name a few, Aetna. There are quite a few organizations who are going to partner at this event. They're going to have their health tables set up. We're going to have testing at that site. We're going to have vaccine. We're going to be offering all 3 vaccines. And we're also going to do some other things such as de-stress. You have a yoga place where people can de-stress after taking their vaccine, and recognizing that we understand not everybody, is able to walk away and feel good about it. But on the front end, we're also going to have doctors there. So the health department lead physician will be there on hand with numerous other medical professionals, but he will also give remarks, talk about what he's seen in the Prince George's County community where FedEx Field is located. And then hopefully the plan is those 12 to 24-year-olds or anyone else in the audience will get their shot if they haven't done it thus far. We'll also be offering and having some nice giveaways. We're talking about getting back to school. So, school supplies will be in the offering, as well as some cards for the grocery store who is supporting us. And someone mentioned Urban League. That's Urban League is, Dr. Cohn mentioned Urban League. Urban League is actually partnering with us, the local NAACP as well as the local school jurisdiction. So that's another method we're using. And this is kind of bringing it all together, showing how we got into the community, how we've been successful thus far, demonstrating the work that needs to be done, and then targeting and looking at that 12 to 24-year-old group. Our governor will be there. The Maryland Department of Health will bring comments, and we're looking forward to being a wonderful event.
Wonderful. So I think probably that you all stole a lot of Dr. Cohn's thunder here, but in terms of, pop-up events, partnerships, trusted community leaders, but Dr. Cohn, I'm going to turn to you. What about vaccine?
Yeah. I would just say ditto to everything General Birckhead and Matt just said. I think, that is exactly what we want to be seeing happen. I think two quick things to add. One is that we can't ignore that there's misinformation that is driving some of this vaccine hesitancy. That is, it is incredibly unfortunate. It's not going to change. And I think understanding that people really do, it's not misinformation to the people who are reading it. And so while we know that that information isn't accurate, it really is meeting people where they are and trying to address their questions with sincerity and empathy, and potentially needing lots of opportunities to do that. So it's offering somebody a vaccine, not just once, but 2 or 3 weeks later and 2 and 3 weeks later, and still coming back around and really not giving up on a community or anything like that. There is one tool that many jurisdictions have used, which is a rapid community assessment tool. Takes the health department can use it when they have a particular concern and trying to understand what is hesitancy at a local or community level. And it's a series of activities and short surveys that they can do, and really jurisdictions can adapt it to their needs. But a couple of jurisdictions have done it on college campuses to understand what college students are concerned about or why they're not getting vaccinated. And in some rural communities, they've implemented this, and it really highlights what the true barrier to those individuals are. And so that people aren't just assuming, well, these people will never get vaccinated because of this, but it really documents and takes you through those challenges and can help you target communities where vaccine hesitancy may be particularly profound and difficult.
Wonderful. So we've got a question that relates to this topic from the audience, but sort of the flip side of confidence. I don't want to say fear. We're talking about empathy and understanding people not making assumptions, but certainly, there is some recent data on breakthrough cases among vaccinated individuals, and I know. On the one hand, I've heard, I'm just going to lay it all out there for you, Dr. Cohn, and have you answer this, but I'm adding to the question to editorialize to say, I've heard among some public health communities that there's, concern that breakthrough cases may de-incentivize getting the vaccine. If I get the vaccine and I'm still going to get COVID-19 potentially, of course, we know, it drastically reduces risk of death and severe disease and hospitalization, but also just, so speaking a little bit to that concern, but also, the audience question around, have you seen any change? And I think we have nationally an uptake as a result of that, of vaccine uptake. So increased vaccination rates as a result of concern around, I think, probably the Delta variant and the breakthrough cases.
Yeah, so there's a lot to unpack in that question, but I'll do the best I can.
Sorry.
No. So yeah, there's a lot going on. We are understanding more and more about the Delta variant, the impact of the Delta variant on vaccine protection, and how to reduce spread. And I think, the big takeaway message is that there is evidence that being vaccinated is not protecting you from getting infected and transmitting the Delta variant, but it is absolutely protecting you from serious disease and hospitalization and death. The other thing that's starting to happen is that we have, I think it's nearly 90% of older adults are vaccinated, depending on the age you cut off, but over 85 to 90% of older adults who are the most likely to be hospitalized are vaccinated. So the proportionate, people are seeing increases in hospitalizations in older adults, and that is likely due to multitudes of reasons. But one is just that so many older adults have been vaccinated. So even if a very small proportion of them are having breakthrough cases that require hospitalizations, you're seeing more vaccinated people than unvaccinated older adults just because of the denominators that you have to start. The second thing is that older adults and people who are immunocompromised and things like that were vaccinated first. And so we do see that there is both likely a combination of waning immunity, which we expected. I mean, the vaccine effectiveness of this vaccine was just, overwhelmingly good. And this is not unexpected, but it does create a really challenging communication problem. There will likely be a need for some groups of individuals to get an additional dose, and that we are working on that quickly. But especially people who are immunocompromised or older individuals. And so while we're figuring out while we still need to collect more information on whether or not a third dose is safe and is going to work and all of that, in the meantime, the only way we can protect these individuals is to get everyone around them vaccinated and to increase coverage in these communities. We are seeing Delta variant hospitalizations and deaths rise in communities with overall low vaccine coverage. So it's that is allowing transmission to flourish. The Kindle is just ready to explode, and we're seeing some breakthrough cases in those settings. But we are also it's a sad result of serious hospitalizations and deaths in younger adults. We're seeing more younger adults coming in and getting vaccinated in the last week to 2 weeks. I think we're nearing, I think we had sort of come down to about 300,000 to 500,000 doses a day. And I think we're coming back up to 800,000 to, hopefully 1 million in the next couple of days. And so whether or not those are the people that need to be vaccinated, we're hoping that it's not a bunch of people who have gotten 2 doses and are coming back and saying they weren't vaccinated. But we believe that what we're seeing is people in these communities are realizing that COVID is not just a blip. It is here for a while, and it is still causing very serious disease. And in those communities, especially, we believe we're seeing people coming in for the first time to get vaccinated, realizing that, this is more than just the flu.
Great, so we have 7 minutes left, and my challenge to us is that we have 2 more questions. One I want to ask, and one that's coming from the audience that I'm happy our last question because it's better than my last question. But I want to just real quick, like a 30, 45 second response. You brought up booster shots potentially on the table, to be determined. Also, there's talk of the authorization for children under 12, probably coming in this calendar year. I'm wondering if Dr. Cohn, but also General Birckhead and Matt, if y'all want to touch on what lessons that we learned from the winter and the spring that we can apply if we are rolling out those boosters or rolling out those shots to younger kids. So Dr. Cohn, I'll start with you and then
I'll start.
Yeah,
But
I'm going to ask you to keep it sort of short so I can ask you.
So the best news is a lot of the lessons that we learned initially were because of our short supply, and we have got plenty of supply now. So I am really hopeful that as boosters do roll out to those who need them, that there will be easy to find, and it is going to be around getting providers to understand who needs booster doses, making sure people know where they can get them, but we're not talking about mass vaccination clinics and things like that. I think there are doses of vaccines nearly on every street corner, except for in some of the very rural areas still they have to take those doses out, such as in Alaska. So I'm hopeful that a lot of the unfortunate lessons that we learned, they won't be repeated this time, but it really is education, telling people lots of different information in lots of different ways and tracking those doses, making sure people have that information about which vaccines they got and when they got them.
Great. Matt or General Birckhead, anything to add? What do you learn?
From Alaska's perspective, it's really engaging with primary care physicians and our pediatricians. Really, those vaccines for children, which is a federal entitlement program, really involving the VFC providers. They are great at immunizing and just making sure that they're engaged, they're up to speed, and really they're vaccinating their population.
General Birckhead.
Yes, I would say, going back to something Dr. Cohn said about using a survey, but I would say you continue to use a sensor in the community to find out what's going on and staying on top of the message that's coming out into your community. And recently I was at a site and they handed out a card. It was well done and it had very misleading information about vaccine on it. So I think that we have to continue to use our sensors and know that those are out there, be ready to debunk that with the professionals and continue to knock down barriers, be persistent and communicate a lot, over communicate actually.
Wonderful. So the last question comes from our audience. I think it's really the million-dollar question that a lot of state legislatures are thinking about and is really looking even further forward beyond 2021. So Jimmy Grist from Missouri asks, from your point of view, what can state legislatures do between epidemics or pandemics to support you in your work before the next public health crisis comes around?
Well, I'll jump in with my answer. That's a great question. Support adult immunization. We need to get our adult healthcare providers and pharmacies as good at vaccinating as our vaccines for children, our pediatric and family practice doctors are. And we need a safety net to be able to reach at-risk, vulnerable adults with all of our routine vaccines, which will be critical to ensure we can rapidly reach those individuals with pandemic vaccines.
I would say that being able to institute and institutionalize the hard work that we've done thus far, the Vaccine Equity Task Force here in Maryland has created in conjunction with all our partners, a wonderful network. And if we could then use that same framework that was intentional for other things, such as adult vaccine going forward, that would be wonderful instead of reinventing the wheel.
And from Alaska's perspective, I'm just going to second what Dr. Cohn said. We're great at vaccinating our kiddos, but it's our adults that we struggle. And there are more vaccines than just COVID-19 vaccines that adult needs. Really pushing other vaccines like Shingrix for shingles, and then just making sure that adults are vaccinated, as well as being aware that flu season's coming up and we should prepare for flu season and really getting our adults vaccinated. And so really just kind of building off the coattails of what we built with COVID-19 vaccine and really establishing kind of that one line kind of direction with adults to get them vaccinated.
You know, I think there are mostly adults on this call in our audience, so hopefully they're taking heed to get their flu vaccine. Unfortunately, we have about 30 seconds left, so we have to end there. I know there's so much more I want to ask you all and hear from you all, but I want to thank our panelists so much for being with us and sharing your expertise. It's been really valuable and really interesting to learn from you all and think about new things that we could be doing in our states.